Alex Vaccaro had the brown hair that he still has on his ID. And one of the, I think the most remarkable things about this is given the fact that we see it so often, there really is not a great evidentiary basis to suggest one kind of best treatment algorithm. And so it ends up being a battleground where a lot of things happen, where the implant companies are fighting for, views, fighting for cages, fighting for approaches. And really a lot of the times that is a big indicator that it's one of the areas in spine surgery where we don't really know what the hell we're doing. When there's a million competing potential treatments, that kind of locks that in place, that we don't really know the best way to treat this. And the last point of our introduction before we'll jump into the cases is more sort of a philosophical mention than it is actually suggesting that any bundle would necessarily include implants. But, in the sense that we are all stakeholders at some level in a kind of cost of treatment consideration, given that at some point healthcare is a rationable item, there is probably a difference in treatment costs between some of these different approaches. And so that's something that I think is not maybe readily apparent in the day-to-day of a practicing spine surgeon right now, but maybe a consideration in the future. So I think without any further talking, let's jump into this. And we'll start with our first case presentation.
All right, Dr. Kepler, thank you so much. I will lead off because mine is likely the most vanilla and boring of the four options we'll discuss. So this is a case of a elderly gentleman, 80 years old, with left greater than right leg pain, activity-related back pain. He had undergone exhaustive non-operative treatment, PT injections. His past medical history is notable for quite a few vasculopathic diseases, peripheral vascular disease, coronary artery disease. He's had myocardial infarction, stents. He does have trace weakness in his left kind of L5 myotome, otherwise neurovascularly intact. Pre-op x-rays, you can see kind of a grade 1 subtle slip here on the lateral. Otherwise kind of diffuse disc collapse. You can also see some calcifications of the great vessels. So this guy's not the picture of health, but on dynamic films, flexion extension, you see that he does have a little bit of motion here on flexion and reduces on extension. And so a representative cut of the MRI at this level, you can kind of see a little bit of a facet cyst out here along the left 4-5 facet there, with kind of diffuse disc bulge, kind of lateral recess foraminal stuff as well. And so, this is the first treatment options. We'll go through everything, but for this patient in particular, I think the thought process, getting back to Dr. Kepler's initial point, was this is an 80-year-old gentleman with a significant past medical history. He's a vasculopath. We don't really know, not to be morbid, but his life expectancy is probably not that of a 50-year-old who's the picture of health. And so for him, the name of the game for us was get in, get out, stabilize the dynamic listhesis, decompress the neural elements, get rid of that facet cyst, open up the foramen from the inside out, and see what we could get for him. And so all we treated with this gentleman with was a standard open wide kind of PLDF. Those are the kind of, I think, 6 weeks or 3 month post-op films. And he did well, resolution of his leg pain. So kind of easy one to start us off.
And, I say this from a position of this, like may very well have been my patient. But, maybe it's a mark of my eyes or the fact that maybe it's that my light in my office isn't that bright, but the dynamic nature of the slip was not that apparent. I think that maybe even going one step further, like, is there a role for PLD? If you really are talking about getting in, getting out, what about a non-fusion strategy? And it's a little bit kind of beyond what we wanted to talk about here, but I think I want to bring it up for one reason, which is that in trying to sort out degen spondy, once upon a time we published a paper with a classification of trying to break these patients into different groups with the idea that some of them may need less and some may need more surgery. And I think this case sort of begs it.
Yeah, I would think that consideration of the decompression alone, particularly with the orientation of the sets and the, like you said, the minimal amount of slip is not, and I don't think that's kind of out in left field. I think actually that's a good suggestion to consider.
Yeah. Did you guys do a big formal fusion, or, you know, these are little screws and big osteoporotic pedicles without a lot of bone graft? I don't know that this is adding a lot to it other than helping out coding.
Yeah. So, I mean, again, like assuming this is, I'm not sure this is my practice, if this is my case, but assuming that it is, and it probably is, you know, those would have been probably 6.5 millimeter screws. And then, you know, we'll take whatever local bone we get, and then I would either put 10 or 20 cc's of like a cortical DBM product. And so, you know, that part of this may be that it isn't the most radiodense graft option, but it would be either 10 or 20 cc's on top of, you know, sort of what you get from, you can see like probably taking just about all of 4 and at least some of the top of 5. But yeah, it's not super robust. I agree.
You know, Chris, I liked your statement in the very beginning about how we have all this data, or we don't have all this great data without any clear-cut, you know, options of what is better than another. And I think that this is fine. You know, it reminds me of the old time days before we had internal fixation, just would do a decompression of posterolateral fusion. And I do agree with Jack that those pedicle screws look awful small, and I don't know what they're holding. And he probably could have gotten away, maybe, you don't know for sure, with you know, just a decompression. But the other thing that we tend to ignore is the place for like a Coflex, which you do a real decompression and it gives you a little bit of stabilization. I know the LimiFlex study is finished. I don't know when that's going to be finished, and that would be another option. Minimally invasive without increasing the stresses on the level above or below. And it looks like his 3-4 levels, almost an auto fusion.
Yeah, it's not, I mean, and below too. I mean, nothing's doing above or below, right? You know, these guys had 80 years to get stenosis at L3-4 and L5-S1. He didn't get it yet.
Right.
Todd Alleman from Stanford actually just this morning at this meeting presented the FDA trial on the LimiFlex, and much like the Coflex, as you'd expect, the results were similar, with less blood loss, less hospitalization. I mean, it's less surgery. So it was very similar to the Coflex study, but in fact had less spinous process fractures than the Coflex study had. So, you know, they had good results. What the FDA is going to do with that, you know.
And, you know, being someone who doesn't, you know, really haven't, since I don't think I've done a Coflex since I was a fellow. But, you know, assuming that the other procedure is similar, what are you doing about if you need to decompress directly the foramen? I mean, is there a route forward for that? Can you get away with taking most of the spinous process, or are you really kind of working up and under to get to that L4 foramen in that setting?
Well, Chris, you know, having been in the LimiFlex study, you can actually do a better decompression than you can do with the Coflex, because the Coflex, you know, you really do have to preserve a lot of these spinous. Right. You still have to retain a certain amount with the LimiFlex, but as far as, you know, the length of your decompression, you have a lot more latitude with the LimiFlex. So it's a lot less digging under and looking under.
Right.
This is Izzy. One of the things I just want to bring up with this, in deciding how extensive you need to be with these degenerative spondies, we need to really know what the patient's expectations are, because there's a difference between an 80-year-old who's going to want to go out golfing and play tennis and the 80-year-old who just barely gets from the bedroom to the bathroom. And that may play a bigger role in our decision making at some point, and we're still very deficient in doing that kind of an assessment on our patients.
Agreed.
I think to play off that a little bit, Will, you mentioned that there was a facet cyst on that left side. You know, it might have been a little bit of hypertrophy ligament, but if that were a facet cyst, you know, does that change your treatment algorithm? You know, in a 50-year-old, it probably does. In an 8-year-old, the question is, does it still? And I think that gets to the question of probably patient needs and expectations. A facet cyst probably implies some more underlying instability. Maybe we're seeing alone by the FlexX, although there is some definite instability there. And the question is, you know, does that influence your need for stabilization in that setting?
I was really, when I kind of did a deep dive, coming out of fellowship, it was sort of like you had a facet cyst, that means instability, that means fusion. And so the first couple of years, I sort of like plunged ahead with that as my mantra. And then when I kind of took a step back and actually looked at what the data suggests, it's not, the recurrence risk is not that high. I don't know. I was sort of underwhelmed by, there's some variation obviously from paper to paper, but I was underwhelmed by the likelihood of recurrence, which, maybe didn't match with what I had been told. And so since that was 2 years ago, I think I started basically, I don't see gross instability, assuming that there's not, and I signed up a guy today who's, I'm just going to resect the cyst, and I made up a number that I pretended was the recurrence rate and said, if that was it, would you do it? And he said he would go for the small surgery. And so we're going to do a, hemilaminotomy instead of a fusion. So
Well, I see Jeff Rowe and Peter Derman on the list here. Is there any MIS or endoscopic options for this?
Well, I was just going to say, as facet cyst goes, I press them all the time. Isolated decompression, as long as there's no gross instability there. So, Chris, I agree with you there. And similarly, I've looked at the data, and it's not that impressive. And just counsel patients appropriately.
Yeah.
If they recur, then they get a fusion, but they haven't burnt any bridges by doing it. And then, I'm a big fan of endoscopic and tubular decompression. So, unilateral hemilaminotomy, bilateral decompression, and the data is pretty good that the progression rate of spondylolisthesis is lower if you do it that way.
Yeah, and I agree with what Peter just said. I think that, from my perspective, I always go from less invasive to more invasive, and especially in an elderly patient with lack of radiographic evidence of gross instability, somebody that has more radicular symptoms rather than low back pain. I tend to opt to go with a decompression first and see how they do. If their radicular symptoms improve, then they feel great, and you might have bought them some years before they may ultimately need a fusion, but at the very least you've done a less invasive procedure that could be done in an outpatient setting.
Good. And so I'm going to stop. We're going to move to the next case right now. I'm just going to throw this out there. If anybody who's watching has interest in it, check out that CARDS classification paper. I don't think it's like the end all be all by any stretch of the imagination, but I think it sets at least a theoretic framework for the possibility of doing a study, whether it's, MIS decompression versus open decompression versus fusion, for seeing if there's some subgroups of this patient population, maybe this last one would be a good one to show that there's really not a difference in reoperation or patient satisfaction or outcome without doing a fusion. So just to put in the back of your mind, email me if anyone's interested, because I would love to. I've been trying to get that going kind of without a ton of success because I don't have enough people waving the banner. So let's go ahead. Derek Chu, take it away. Wait, Derek, no, we can't hear you. You must be muted. Go back. He's sort of a quiet guy, but not this quiet.
All right, can you hear me now?
Yeah, that's perfect.
All right, so we've been talking about a different approach to L4-5 spondy. Our patient is a 51-year-old female. She's had several years of back and bilateral leg pain, more on the left side, going down kind of an L5 distribution, posterolateral thigh, calf, feet, with associated numbness and tingling. She has improvement with leaning forward and sitting, no bowel bladder issues, and she's done extensive non-operative treatments, physical therapy, etc. She works as a teacher. She's 5'5", pretty big lady, BMI of basically 40. She has pain with the range of motion of the spine, and neurologically, she's pretty much intact, maybe a little bit of weakness in the EHL, but otherwise 5. So the preoperative x-rays demonstrates a grade 1, maybe 2 spondy at 4-5. There's disc collapse at 5-1. Otherwise, there's no coronal imbalance, and the other disc heights are pretty well preserved. On the Flex X, you can see dynamic shift between the flexion and extension films. Again, you see the collapse at 5-1. And then when we look at the MRIs, focusing at 4-5, because that really was her problem. 4-5 has moderate central stenosis. You can appreciate there's fluid and bilateral facets. which reflects the dynamic instability of the 4-5 segment, maybe slightly anterior psoas. Otherwise, 5-1 was unremarkable. I don't have the MRI images of that, but going through the foramen, the left side, pretty severe foraminal stenosis. And then on the right side, pretty severe foraminal stenosis as well. So, for this lady, large patient, foraminal stenosis, moderate central stenosis, pretty amenable psoas. The plan in a big lady was to try to get indirect decompression and fusion to stabilize that dynamic instability. So for this patient, the approach was chosen to be a direct lateral approach to transpsoas, to do a lateral fusion, restore the disc height, restore the foraminal height, and then fuse her percutaneously from the back. And here are the intraop x-rays, which demonstrates pretty nice restoration of that disc space and foramen. And then 6 months follow-up, pretty much, you see some bony fusion, and otherwise everything else is stable.
Sorry, Derek, did you address the L5-S1 foraminal stenosis?
We did not, just based on the MRI. I don't have the cuts of the 5-1 segment, but it was thought that her symptoms were basically all from the 4-5 segment. So decided to leave that alone.
Can't do it with an XLIF either.
Right, and I see what Izzy's getting to, because if her BMI wasn't 40 and you were doing her anteriorly, wouldn't you have included 5-1?
We would have considered, addressing 5-1 at the same time, but
Derek,
go ahead.
Also, just to expand on that, how do you know? Help me figure this one out. How do you know that the principal compression of L5 is at the 4-5 level, where it's the traversing root, versus the 5-1 foraminal level?
Was she a 4 or a 5 Redick? I don't remember.
I think it was mostly 5, like posterior lateral thigh, posterior lateral calf. So more 5, not much anterior symptoms.
So that's something that I struggle with every day, figuring out which area, because we very often see the foramen and the lateral recess. If you're doing a decompression alone, that's pretty easy. You go from behind, you decompress the index level, and then you extend down to get the foramen at the level below in that superior articular process by undercutting it. But in this type of case, someone who's morbidly obese like this, I'd find this a really big challenge. And I must admit, I would really struggle with the decision-making here.
Is this perk in the back too?
Percutaneous, correct.
Yeah, it looks perk in the back. So, there's nothing done to 5-1.
Yeah,
I wouldn't have the guts for it, to be honest.
Well, but I have to agree with Izzy, because, you're showing a 6-month follow-up, Derek, and there's nothing more sobering than long-term follow-up. And she's morbidly obese, and that level at L5-S1 has really collapsed down, although we don't have the MRI scan.
Can't agree with this. Can't collapse anymore. That's the only thing she's got going for her.
Yeah, that's true. Can't collapse anymore. But anyway, it's just something to think about.
I'll chime in here. This is actually one of my cases, so I can speak to it a little bit. So in my decision-making, this is to touch on what Dr. Lieberman was talking about. There was a large dynamic component to her pain. And I think when there is a large dynamic component with that type of instability, I don't know that you can hang your hat on it, but it is that type of discussion where less is more. I do talk to them about a minimally invasive approach. I think it's a different type of procedure for a morbidly obese patient to have a large posteriorly based procedure versus a more minimally invasive procedure. And should she still have radicular pain after this, then maybe she's amenable to a single level MIS, maybe tubular decompression for that foramen. That's one. Two, I think the value there of selective nerve root blocks can be valuable. If you hit that L5 nerve root in the foramen and she doesn't really get symptomatic relief, I think that may be partially your answer. And then three, we've done this in our group, and there's some, pretty poor quality, not absent literature, talking about kind of what is the natural history of a severely degenerated 5-1 disc in the setting of a 4-5 spondy. And at least in the poor quality retrospective data, both in our own series and some other groups, it seems that patients do as well, if not better, if you just address the 4-5 level in that setting rather than 4-1. So I think there's a couple of reasons to go here for 4-5 alone, but I think all those things are important in decision making in a case like this.
Well, David, I don't question what you did because she was morbidly obese. I would tell her, we're doing your 4-5. You have a problem with 5-1. You're losing 100 pounds. We'll operate on you.
or I mean, so you're doing a 360-degree fusion. I mean, like, you know, maybe I think maybe what Dr. Lieberman's getting at is this like an AP 4-1, you know, or a, you know, lateral or a 4-5, and then you've blow the Freeman out. Wait, Derek, can you go back 2 slides? Does the MRI not show the 5-1 Freeman at all?
Let me try to go back.
Oops, that's not it. Yeah, that little thing.
And can you show the axial through 4-5? Those psoas were pretty anterior, if I remember.
Yeah, I did. Yeah, I thought that they were. Yeah, okay.
Yeah.
Yeah. Any comments on the logistics of doing a direct lateral with psoas that far toward the front?
Mike Heise, you're on. Mike?
So I'll comment on this a little bit.
Yeah, I'm muted. Sorry. Yeah, that one's on the borderline for me. Maybe on the right side, amenable. Left side's a little tough, but something I would consider. I do like just addressing that one level, though.
Yeah, for me, so I'm looking at the femoral nerve bundle, which you can actually get a cut of right there. And if you dock relatively anteriorly in that psoas, and you're running free, you know, kind of free EMG the whole time, you can't push back all the way, but you can push that back a little bit. And if you're working relatively quick in that disc space, I think that is safe for me. I think a little bit more anterior than that, I might shy away.
So there's a left approach, David?
I'm sorry?
You think there's a left approach?
You know, to be honest, I can't remember. I'm not 50-50, but I am pretty liberal with my right-sided approach. I can't remember honestly which approach this was.
That's both ways.
Well, I did note that the cage was well anterior, which is nice. It does keep it away from the neurovascular or nerve bundle.
Right.
So that's good.
All right, Derek, would you mind advancing it?
Sure.
All right, I'm gonna talk about the next one, and this is more of a classic approach that we learned to do quite a bit here at Jeff, and it's the anterior approach where you put the inner body from the up anterior approach, and then you flip the patient and do the either perk or open posterior. We have, an elderly female, 77, with many years of back pain. I think it was over 20 years of back pain, bilateral extremity symptoms, left more than right. She had numbness and the tingling. And it seemed like she was mostly affected L4, L5 distributions. It improved with sitting. She was worsening over the past few years. She tried every possible non-operative management, PT, multiple injections, and she didn't get any relief. And so, we decided to go in a little better body habitus than Derek's patients, 5'1", 165. She did have some weakness, 4 or 5 in bilateral AHLs, and sensations only diminished on the left L5 distribution, not really on the right. I can't see that. And then pre-op x-rays. Here we have AP and lateral. We see again a grade 1 spondy, 4 and 5. Slightly collapsed disc space here, 5'1", somewhat collapsed as well, but a 3 to go throughout. And we measured it for the team, and there was it was 3 or 4 millimeters going to 8 millimeters. So it was also dynamic instability. We thought that it would be amenable for surgical intervention. Pre-op axial and sagittal T2 MRIs. Again, we focus on the L4-5 level. You see the spondy again, and you see bilateral foraminal stenosis. Again, I think in my eyes, I see a small facet cyst right here, more significant on the left than the right, which kind of explains her worst symptoms on the left. Fluid in the facets as well in the foramen here. See some compression here on the left side. L5 is a little tight, not as tight as 4 compared to the other ones. And then on the right side, there's not much impression there. It's mostly left-sided, which is it fits with her symptoms. And intraoperatively, we decided to do an anterior inner body device, put screws in the front and then flip. And I believe this was where percutaneous posteriors as well. And that's it. I don't think we had. Yeah, that's it. we got the Intraop Flores. I think she hasn't had their post-op visit. It's a pretty recent case.
What animal is putting staples?
That was the anterior surgeon. I believe the vascular surgeons in our center, do staples in the front.
You know, Chris, it's funny to hear orthopods talk about staples. I mean, we never use staples.
No. I mean, the joint replacement guys do, but like they're barely surgeons. So like we can't really expect them to learn how to stitch.
So this is Jens. So one question about fusion. So technically beautifully performed. Can you go back to the flexion extension films? Sure. This is always a great question for me, and I'd love to hear your thoughts on this. So this is one of those degenerative spondies. It's kind of like, it's a bit unstable, but on the general perspective, I put that kind of somewhere in the middle of the stability continuum. So it's not horribly unstable. If this is an older 77-year-old who's not exactly doing crazy yoga, what is the role of a decompression of the lateral recess in the foramina and an interspinous device, dare I say a Coflex or something like that? Is there any thought for that in your center, or is that just not happening?
You know, so if we hadn't nicknamed the PCF C3 to T1 the Jefferson Special, then the AP would be the Jefferson Special. So like, first of all, we kind of have a hard time philosophically with that, but we are not doing a lot of intraspinous spacers here. You know, we don't have hardly any patients who are from the West Coast, and that's a part of it. But all it takes for me was one presentation of seeing Yun Bei talk it up to think like it's like the best thing under the sun. So, but I've always been a sucker for his enthusiasm. But I don't have a lot of experience and other than a few with Dr. Hillebrand, our guys probably don't have a hell of a lot of experience with the interspinous spacer. So why don't you tell us what your take on it is?
I think for me, the fascination of degenerative spondies is that we still don't have all the details that are relevant. So translation is one factor, type of stenosis is one. And even the type of stenosis, is it more facet? Is it more ligamentum? Is it a synovial cyst, etc.? Disc bulge is another one. But the other factor is truly the facet joint anatomy. So here on the axial facet joint MRI scan, what I see to my interpretation of those limited images is a very congruous facet joint. So this is a beautiful case for me of a patient who kind of doesn't have these big old fluid signs in the joints, and she needs just a little modicum of stability. And if she's not a high performer, again, there's 77-year-olds who are just unbelievably active and use their trunk. If she is a moderately active person, I have found this to be a reasonably less invasive surgery that hopefully will not kind of create this chain reaction up and down the spine. So that's my take. And I'm going to fish for Scott Blumenthal, but I don't see him on the panelist list here right now. But I'm going to look for some TBI. Oh, great. I'm going to look for some TBI support here.
No, we in the older patients under a circumstance of, predominantly stenotic symptoms and any not too unstable spondy do favor the decompression Coflex. It's like you said, it doesn't cause problems above and below. The failure rate, is actually pretty low, to be honest. The interesting thing about decompression alone for this kind of circumstance, they presented a paper at the Zalma meeting just this past day. That one of the risk factors of progression is a tall disc space.
Yeah,
this person had a tall disc space.
I wouldn't say this. I think this is like the opposite end of the spectrum for me in terms of that first case. With my willingness to do like a decompression alone, I think this one is probably for me. This one it's tough when it's a tall disc, and I think this is what you often see. For me, it's hard to make a real big case that you need like inner body height, right? Because they're already a tall disc. And correspondingly, this is not a huge femoral disc fragment. I think it's sort of a front to back. If there's compression in the frame in there, it's kind of front to back. So I think this is like in my practice, this would be a put screws in, posterolateral fusion, hope that you outrun the non-union if it develops, and leave it be with that. But I'm totally willing in a situation like this to think about a Coflex. Other than Yun Bei wooing me, I haven't really had much experience.
And that's why we're so scrutinized by the insurance carriers over fusion indications, because you present this case, what's the joke, to 5 spine surgeons, and there's 6 different opinions on how to fix it.
100%.
If you look at the orientation of those facets, they are almost coronally oriented.
Yeah,
so this would be a good facet to do a little undercutting for ammonotomy, whereas if you had more sagittally oriented ones, you'd worry a little bit about no fixation, or maybe even just interspinous with the orientation being 90 degrees different. But this is a good one for undercutting without losing a lot of stability.
And I don't know. I think I agree with Chris, because the disc height is so plump. I would be concerned, especially with the translation backwards and forward, that a decompression alone would not be successful. You might consider a Coflex. I'm not sure why Coflex works, but they work. I mean, the grip on the spinal process really doesn't hold anything. So it's beyond me. Even though I've done a lot of them, I still don't know why it works. But I think this is one of the
interlaminar.
Oh, that's right, interlaminar. Yes, but
interlaminar.
I'm still not sure why they work.
That's a nice marketing phrase, interlaminar. If it was interlaminar, they wouldn't have had a 15 to 20% spinous process fracture rate in the study. And I'm a fan of Coflex.
Yeah, well, I mean, that's like the same story, right? Like that's like only news to someone who hasn't been around through the X-Stop era. It worked great until it didn't. All right, let's, Jose, if you wouldn't mind moving it along. We're a little bit ahead of schedule, which is sort of the Alex Vaquero way. So
all right. Let's move it back 1 second. All right, so hey guys, so I'm Bryce, last fine fellow presenting. Everyone can hear me?
Yes.
All right, perfect. So, so this is the last case to wrap up this talk on L4-5 spondy. So this is a case of a 72-year-old female, had 3 years of low back pain, right greater than left leg pain, kind of the L5 distribution, failed normal conservative management, past medical history, just significant for rheumatoid arthritis, non-smoker, no previous surgeries. BMI was 34, had some weakness in the right tibia and EHL. A little bit of decreased sensation in the right L5 dermatome, otherwise full strength and sensation. So here are the x-rays. So you can see a little bit of a coronal imbalance on the AP, and on the lateral you can see that there is a slip at L4, L5, kind of grade 1, almost grade 2, and it does have a dynamic component of instability on FlexX views. So this is not the best quality MRI, but you can see kind of at the L4-5 level, there is a component of some facet hypertrophy, some lateral recess, and foraminal stenosis bilaterally. The symptoms were worse on the right side. So in terms of options, so we've already discussed options, anterior-based procedures such as ALIF, XLIF, and then kind of open posterior-based procedures. So as the more MIS-oriented person amongst my fellow class, I had to go with this, which is MIS TLIF. So this is a navigated MIS TLIF. So this is the only fluoro shots that are actually taken during the case. So everything else is using navigation, which is pretty cool. And did a expandable titanium interbody cage and a bilateral decompression and percutaneous pedicle screw fixation. And interestingly, because we did navigation, you can actually see the quality of the decompression too on these 3D fluoro shots. If this will work, it might not. All right, that's not very helpful. Let's try this one. All right, also not the most helpful. Let's try one more. Axial is probably the most enlightening about this. But basically, show that again, pedicle screws appropriately placed, and again, you can get a really nice. And again, this is not CT quality. This is Z machines. This is cone beam 3D fluoroscopy. You can see you can get a really nice wide bilateral decompression through a tube and 2 millimeter incisions, or sorry, 2 centimeter incisions. And again, this is a relatively recent post-op, so I don't have the long-term follow-up images, but patient discharged post-op day 1 to home, stopped all pain medication post-op day 5, and really had no meaningful pain at their 2-week post-op visit.
And so I want to tell Bryce something he doesn't know is coming, which is that Alan and Alex and I got together and we're revoking his fellowship, certificate because he presented an MIS case at a national conference. And we're also going to revoke Mark Kurds, even though he graduated from Rush, for the same reason.
Yeah, no, this is whatever the opposite of the Jefferson special is. This is black magic. So, but it worked really well. The patient's happy. Well, we'll see if this thing actually fuses or not. But that's a story for a different time.
Bryce, in this case, what do you guys put in the disc space, and did you do a contralateral fusion?
Yeah, so we burnt out the facet on the contralateral side, kind of standard practice. We didn't kind of do like a Wiltsy, like burring out TPs and do like a full posterolateral fusion, but we did burr out the contralateral facet and stuff a little graft, kind of autograft down there from chopping out the facet. And then in the inner space, it was again sort of ground up facet plus some allograft DBM.
And when you go out and practice next month and you're doing MIS TLIFs, what type of interbody do you think you're going to be using?
So I'm probably going to do an expandable interbody just because it avoids some of the problems of cage backout that you occasionally see with these, just because it's a little bit harder to distract in MIS TLIF versus an open TLIF and get a big disc space distraction and put a big cage that'll stay in. So the expandable interbody is nice for that. There's a couple different ones. I mean, there's titanium, there's PEEK, there's kind of more banana-shaped cages. There's benefits to each of them. And I'm probably going to actually do kind of a BMAC, like iliac crest autograft as an adjunct. So there's commercially available kits where you can actually get iliac crest through a percutaneous incision, and I think that's what a lot of people are doing for these two to kind of pump up the fusion rates.
All right, so I'm remiss in the fact that I missed. I was supposed to be watching the chat the last two cases, and I want to back up about a question about it refers to this case and any of the other ones. Is there a hard cutoff on BMI for either lateral or AP? And then what is everybody? How commonly are people pursuing prone transpsoas?
Chris, I think the hard cutoff BMI is a really important one because I'm sure your total joint surgeons are doing that also now. The problem with doing even a technically beautifully executed fusion like what you guys did is in these large people, the problem just propagates very rapidly. We don't have any data that I'm aware of on that. The sport trial had, as we know, cutoffs for BMI.
Yeah.
But so this is anecdotal with all the accompanying caveats, but how are we helping those patients really? Because whatever led her to get that loose facet joint, it's just going to work its way up. And again, in my practice, I do revisions left and right for people who have asked these people. The incidence of adjacent segment disease in these morbidly obese patients is astronomically high and much more rapid than we usually see. So I think barring a clear neurologic event, my strong suggestion is we learn from the interactions of our total joint surgeons and set really rigid rules on these patients and hold them to that, because then a beautifully executed surgery like this will have a much longer longevity. I'm going to shut up now and hear the repartee from the others.
All right, so I'm going to right back, but you don't need to shut up. So my 2 points to that are, number one, sport obviously was limited, right? There was no enormous people in sport, but the stratification in sport didn't suggest a differential in the problems that we care about with BMI, in one of the subgroup analyses. So that is not a generalizable statement at this point because of what you mentioned about the fact that sport had a BMI cutoff. The second point is that would be great to show, but I don't know of a stratification by BMI that suggests adjacent segment disease is different. So like that, but that's an easy thing to do. That would move the needle in a really meaningful way, and in a way that sport didn't have the ability to capture. And again, I think that's a great potential study that is, even in a retrospective manner, is pretty easy to put together, because who's going to wait years for subsequent surgery in a prospective study? It's not really data that you can get that way. So I'm all ears on that. All right, so let's maybe, no one's jumping on maybe the prone lateral. Let's go back to the MIS, our black sheep, Bryce Basks, and the MIS approach this. I'm just kidding. He tricked me into doing one of these this year. It worked out fine. Anyone?
Let me just jump in on something with that. One of the things that I'm always concerned with the transforaminals is the size of the implant and the preparation of the disc space. And much like Jens and many of my other colleagues on here, we see a lot of revisions. And I've just got countless revisions where you've got this one small unilateral T-lift cage placed in. It's beautifully placed the first time, but you can tell the disc space has not really been cleaned out. The rest of the disc isn't filled with bone, and you're using polyaxial screws in someone who's morbidly obese with a huge lever arm carrying that pendulous belly forward. You know things are just going to cycle, and we see them all subside. So is there more of a role for a larger footprint cage in the obese versus the MIF T-lift in the obese on the basis of biomechanics?
Yeah, how can you argue against it? I mean,
I'll here too. Oh, sorry, Chris.
Go ahead. Yeah, you go.
As someone who trained at Rush like Bryce and did a lot of MIS T-lifts.
Can you mute these guys? Hold on. Linda, help.
No. I think you're going to like what I have to say. I do almost none now. I think it's a really sexy procedure because you can do this whole thing through a little tube and this and that. But I agree with Dr. Lieberman. Biomechanically, if I needed something in my back, it's the least favorite inner body. So for me now, a T-lift is only for a patient who I can't do an A-lift or an X-lift on, basically.
Interesting.
Yeah, and I think if you look at people who are doing a lot of MIS T-lifts these days, it probably evolved over time to the point where like a unilateral bullet cage isn't even what a lot of people are doing anymore. People are adding adjuncts like iliac crest to those constructs, or they're doing bilateral fascectomies, bilateral cages, kind of turning it into almost more of a PLIF construct and kind of getting bilateral. And all of a sudden you're doing like, bilateral fascectomies through tubes, and just, it turns into a much bigger procedure. But I think a lot of the people who are doing MIS T-lift have kind of evolved along the way to try and get a better disc space prep, because certainly, having the entire body habitus pivoting on a little bullet cage and some perk screws doesn't always work well.
All right, so I want to. This is not really shifting gears exactly, but because I think it's a general statement, but I think it gets back to the reason that we wanted to talk about this, which is it's a problem that you see so often. It's such a huge percentage of really everyone's practice, and it's not really answered. Which is that this is from Stanley Huang. I hope I'm pronouncing the name right. What are your thoughts on a spondylolisthesis? It doesn't really change on flexion extension, and we're kind of talking about, we talked about at the beginning, which is like, is that a rule? Is that what set of circumstances under no change on flex X, if they gave a good effort, do you think about a decompression alone? And like, not to make it sound like I do a ton of those. I mean, I don't, but I really am intrigued by the prospect of doing it. And I think there's probably a lot of upside to, in a certain patient population, to a 40-minute operation in terms of, instead of an hour and 40 or a 2.5 hour operation, or longer if you're talking about 360.
I do it all the time. As long as it's grade 1 and they're stable and they don't have massive facetted fusions, I mean, there's not even a question in my mind. I just decompress them.
I love that.
I do it through a unilateral hemileminotomy, and you know,
and then you go to the other side. If it's bilateral symptoms, you're just working underneath the spinous on the far side. Yeah.
Exactly right. So like in my practice, there's not really a space for Coflex or anything like that because I'm preserving all the middle stuff. But you know, some of them will fail, and so I think it's all about being very upfront with them. But the vast majority of them don't. They go on with their lives. You know, risk factors, and there's some papers on this, and we've alluded to this to some extent. High disc spaces, you know, higher risk of having listhesis, sagittally oriented facets, stuff like that. But even if they had that, I would still decompress them if they were sophisticated enough to understand the risks.
Like, does B stand for twofer in a different language? Your middle name?
Stage procedure.
Exactly.
Izzy, I'm surprised you haven't brought up John McCullough. John McCullough was touting this years and years ago.
Absolutely. But again, I think it is still very patient specific. And as I mentioned earlier on, we still don't have a good way of assessing the patient demand on their spine and their expectations. Because those with high demand, and it's been brought up a couple times, are going to need something more stable. Those with low demand may not need something more stable. Absolutely, you don't burn any bridges by doing your decompression first. And we can go through that, and quite often we do that. But it's that functional evaluation of the patient that we are missing today. And I do feel that if we have that, we're going to do much better with these degenerative spondyes.
So do you think that comes in like in the way of like a activity assessment or a questionnaire or both? Or I mean, is this like a Gestalt thing, or is this like an opportunity to build a tool?
Am I glad you brought that up? Because I'll put the plug in for our gait lab again.
There you go.
And this is gait analysis and looking what the patients are doing and assessing how they're walking, their balance, their biomechanics, their kinematics, and figuring out what we need to do. Their principal complaint is easy. You get that on the history. But the function and biomechanics, at least for me, is very hard to really establish on the patient's history. Some of these elderly patients are all over the place. You really don't get a good idea of what they can do.
You know, the question that I have is, once you open the box of based on their proposed functional demands, does that make you want to do a more stable rigid construct, which could increase the chance of adjacent segment disease, or to do the lesser procedure like maybe just a decompression or decompression Coflex? I don't know.
Yeah,
whether the activity level helps you decide one way or the other.
I don't know the answer to what the ultimate treatment's going to be, but I think we're going to be able to define that better when we have their function pre-op and post-op.
Yeah, it seems probably easier to make a decision for the low functioning person. For the high functioning person, we don't really know what the ultimate, how all these treatment strategies work. And that's really what would end up making your decision easier, is kind of what the ultimate outcome is, coupled with a patient's demand.
Yeah.
But it's
in a way, it's analogous what Sig Bervin is trying to do with the preoperative risk analysis for the deformity patients. I mean, we really should have it for almost all the surgeries that we do. Multiple choice.
This is a deformity.
Well, okay, that's right. But degenerative folks do it too.
Yeah, exactly, because it's not T10 of the pelvis for everything.
That's right.
Well, listen, any other pressing questions? And we're a couple minutes early. If anybody has anything they'd love to talk about, we'd love to hack through an answer to it. Otherwise, I suppose we can cut it short a couple of minutes.
Hey, Chris, before we sign off, will you just tell us a little bit more about the study you alluded to in the beginning? Because you didn't say much. You just said a few.
So there's a paper that I wrote that really was motivated by Greg Anderson, called it's an acronym, but it's called CARDS classification. And so CARDS. And so the idea about it was trying to come up with seemingly like kind of physical groupings of L4-5 degen spondy patients based on features like the height of the disc, the degree of instability, in the hope that you could stratify these, probably distinct entities into different treatment groups. And so, for instance, there's one group in this classification that it's a totally collapsed disc without much shift on flex X. Like it seems like it's made for PLD. Whereas a much taller disc that is much more dynamic, may, if particularly if it falls into kyphosis, may need an interbody support. And so, again, I think it's just a first hack at it, but we were trying to divide it based on what we sort of thought patients may need, or what may be important distinguishing features in selecting a treatment for an individual patient. And so I think it's a starting point only, but the intention of the whole paper and of the effort was only to come up with groups that you could start studying in the hope of defining who needs what.
Okay, well, that's sort of what we were talking about, a risk analysis. And I think, as you said, it's a start. I like that.
Hey, Chris, so great session. I have one more question. Since we mentioned the four-letter word, the sport trial, how do we nowadays justify putting interbody cages in? I do it. I feel much better about it. I think my patients feel better. But if we look at the long-term sport trial, there are no differences between their screw fixation only patients. There's a slight decrement from my vague memory in the long-term group for the posterolateral only fusion patients, which is another question. And they had more complications and no better outcomes for the interbody group. So did they not know how to operate there in the sport trial, or how can we justify the much more invasive cases?
Can I take a stab at that, Jens?
Please.
My stab at it is that most of us now are doing MIS screws. And despite what people say, it's very difficult to do a really good posterolateral fusion with MIS screws, whether you use percutaneous, true percutaneous, or a mini Wiltse. So you're truly relying on the inner body for your fusion. That's my response. I don't know what everybody else would say.
So, to answer directly, like the big joke is that Chris Kepler practices like, 1987 medicine or 1983. What was it, David? And so I'm mostly PLDF. I'm a little bit of a dinosaur. That's probably why I got gray so fast. But I don't know. I buy it. I have not seen a real big difference and I'm not talking about like my patients do great. That's kind of like a BS thing to say. I mean, like I haven't seen a big difference in the literature that bears out the benefit of an interbody from a clinical standpoint. And so I don't know. I don't do it. I do it here and there. Like I probably have one interbody fusion of any type for every 3 or 4 PLDFs.
Chris, just one thing to remember, Chris. Dinosaurs ruled this planet 300 million years ago for 50 million years. Right. When humans are on this planet for 50 million years, then we can make a statement.
You got it. On that note, thanks everybody for coming. It was a lot of fun. Appreciate it.
Thanks, Chris and David. Take care. Be safe.
Bye-bye.